Welcome to the FMP Essentials show. I am Dr. Yousef Elyaman, your host, and I am thrilled to have you here with us. Whether you're a seasoned functional medicine practitioner or just starting out on your journey, this show is going to be a go-to resource for mastering functional medicine and making a real impact in your practice and community. Thank you for joining us on the FMP Essentials show.
Disclaimer, the content of this podcast is for educational and entertainment purposes only and is not medical advice. Always consult a licensed healthcare provider before making changes to your health regimen. Views expressed by guests are their own and do not reflect those of the host or producers. No statements about supplements or products are evaluated by the FDA and are not intended to diagnose, treat, or prevent any disease. Listening does not establish a doctor-patient relationship. By continuing, you acknowledge and accept this disclaimer.
Now sit back, relax, and enjoy the show. Hello, everybody. Welcome to the FMP Essentials show. I am excited because today we have a special guest, Dr. Tara Scott. Dr. Tara, welcome to the show.
Thank you for having me.
So if you guys haven't subscribed to her social media yet, make sure that you do that. She is well known in the hormone space, and today we are talking about a very important topic. So back to our functional medicine tree. We look at the functional medicine practitioner as a fruit-bearing tree, and that fruit-bearing tree, if you has a trunk, the trunk holds the tree up. If you don't have a strong trunk, you don't have a strong tree. And to the functional medicine practitioner, that trunk is going to be knowledge, and that's the first section of this podcast. So, Dr. Scott, we are going to get into our topic in just a second, but could you give us your 76-second bio?
Sure. I'm a traditionally trained OBGYN and went through, traditional residency. I could cut a baby out in a minute in an emergency section, but I didn't know anything about managing hormones. So I had my own kind of struggles with infertility and hormone issues, and then led me to kind of study more about hormone therapy right 20 years ago before it was really kind of trendy. So I'm a dinosaur in the field. And then shortly after that, my brother suddenly passed away. He was 38. He was hiking. He had a heart attack, but he had every risk factor. He was a diabetic. He was on a statin. He was a smoker. He had high cholesterol. So it seemed like a very preventable death. So I really kind of searched for more than just hormone and menopause education. So that's where I found and did my training at A4M in integrative and functional medicine, got another board certification in integrative medicine. So while we focus on menopause, it's really even more than that. It's really wellness and prevention, metabolic. A lot of women suffer from metabolic issues. So I'm starting to see women younger and younger and younger in my practice, which is why I wanted to focus on perimenopause instead of menopause, because there's a lot out there now with Oprah's special on menopause. But I feel like the group that's really hasn't gotten their day is really the perimenopause people.
Right. And that actually was my first question, like why perimenopause? And perimenopause is that, first of all, how would you define perimenopause?
The actual clinical definition of perimenopause is once your periods change by 1 week. So if you're normally having a 30-day cycle and you have a 40-day cycle, by definition, somewhere in your 40s, that would mean that you're in perimenopause. But using that definition, women can spend 10, 15 years in this perimenopause irregularity, because it's not till you have 12 months without a period that you're menopausal. And so, that time frame has become broader and broader and broader with that clinical definition.
Right. And I think you may have somebody that their periods don't space out, but they're having symptoms and their hormones are out of balance. And unfortunately, I agree with you. I think this population of women could get help, and they don't get help because, like you mentioned, it's interesting how you mentioned that you are a conventional trained OB-GYN, so obstetrics and gynecology. And you would think that being trained in obstetrics and gynecology, that you would be like the queen of hormones. Like you would know everything about at least the sex hormones, but that's not the case, huh?
We aren't given any menopause training. Now, it may be a little different now. I did residency 30 years ago. And I know that for a time before COVID, I was actually giving lectures to the residents. I mean, we're talking 3 a year, so not enough that they really had a big solid foundation. They were doing a reproductive endocrine rotation for 3 months in their third year, which focuses on infertility. And then they would spend a day with me in my office. But then when COVID happened, they were super strict about everything, and I haven't had residents since then. So they don't get very much education, and only if you're interested in it yourself and pursue it. I mean, the time and money that I have spent in my functional and integrative training is more than I spent in my medical school. So,
Wow.
yeah.
Yeah, and I think what there was a lot of muddied water that happened because I know when I was in residency and in med school, there was and started residency, there was the first that whole Premarin thing.
Yeah, in
And
2002.
yeah, so horse mare urine estrogen was like the way to go.
Yes.
And they were just giving everybody the Premarin Provera, and then they said, "Oh, wait a minute, it's going to increase the risk of strokes and heart attacks and cancer. So let's do this. Let's just try to get everybody off hormones." And I know when while I was training, it was let's not put people on hormones unless we absolutely have to. So we were giving them antidepressants and things like that. And it wasn't until later that when I learned about functional medicine, and actually before functional medicine, I learned about functional medicine because of learning about bioidentical hormone replacement.
Oh, okay.
It really opened up my mind because I didn't realize that I didn't know certain things like that you can't patent a natural substance and why they would need to make Premarin. But could you talk a little bit about that whole Premarin Provera piece and the recommendations how they used to be that women should not be on them and how that's shifting?
Yeah, so that study was 2002. And keep in mind that the reason that study was done was not to prove that the hormones were safe or to see what the risks were. That had long been documented since the 70s. So Premarin is hundreds of estrogens, primarily something called equilin sulfate, which is similar to our estrone, which is made in our muscle and our fat. And it's combined with progestin, similar to what you would find in a birth control pill. Now, the action of a birth control pill is to suppress ovulation and prevent pregnancy. It's not to replace your hormones. So it is not, the goal is not there. But at the time that they came out with Premarin, they didn't know how to micronize progesterone in its natural form. So they went with the synthetic version. And so the reason that study was done was, as I mentioned, not to see if it was safe. It was to get a fifth indication from the FDA for prescribing. The current indications are hot flashes or vasomotor symptoms, genitourinary symptoms of menopause, which includes vaginal dryness, going to the bathroom at night, frequent UTIs, painful intercourse, prevention of bone loss, and if you have premature menopause, which is defined as before 45, so or younger. So they wanted a fifth indication, which is primary prevention of heart disease. And in order to do that, the FDA says, well, prove to me that your drug prevents heart disease. So that's the reason the study was done. So they had 5,000 people that didn't have a uterus that took Premarin alone. They had about 8,000 people plus 8,000 people that had placebo. So the reason this gets a lot of attention is because it's one of the largest randomized placebo-controlled trial. Now we have much, much larger observational data, but this one was 8,000 people. And what they found after 5 years is that there was an increased risk of blood clots because it was an oral form and also an increased risk of breast cancer. In the estrogen-only arm, they didn't have those same the same outcomes. And if you look at how this data has been regurgitated, study after study after study, is that 97% of the people tolerated it and did well. And they just came out with that Million Women study where it wasn't just on Premarin, but it was 7 million women, Medicare age, who they studied. That means they were 65 and older, and they studied the effects of them taking hormones. And the dates that they would have studied them, they would have mostly been on this Prempro. And they actually found like a 19% reduction in breast cancer. I think it was, don't quote me on these percentages, but somewhere between 15 and 20% reduction in colon cancer, reduction in mortality just from taking this drug over 65. So we have a lot more data than we did then. But what happened is everyone got scared. They don't understand. And if you talk to 10 gynecologists, I bet you 9 would tell them, don't take hormones. They would say they're going to cause cancer. But
We still have it. We still have
Yes. Yes.
gynecologists, local gynecologists that are very afraid of it. And what's interesting, I think what really opened up my mind was this whole concept that you can't patent a natural substance. And if you can't patent a natural substance, they had to make something that was not the same hormone, but it was like the hormone, so they could patent it. It takes it takes $1 to $2 billion to get a medication FDA approved. So then when they spend that money, they got to get the money back by patenting it. And then, like you mentioned, that they were just looking at oral and they weren't looking at progesterone or progestins. And I think that's why they're so confused. But now this, I'm really excited about this, and thank you again for doing this, because this perimenopause group of people, this is let's talk about, yes, okay, they said delayed period, but let's go to your clinical experience and what you're seeing. First of all, what age range should we be thinking about? And what symptoms should we be thinking about for women that they still having their periods, but their hormones are off?
Yeah, you said earlier, like if they're having regular periods but having symptoms, that's a great point, because I hear from patients a lot that they go to their doctors and they say, well, you're having regular periods, so you're normal, you're fine. But
Right.
that isn't the hallmark. So yes, that is the clinical definition of perimenopause, but you can certainly have issues. Now, think about it from an obstetric point of view. If a woman over 35 goes in to try to get pregnant, they are going to be labeled as advanced maternal age. I've even heard the term geriatric pregnancy. Why is that?
Wow.
Because their eggs are old and there's an increased risk of chromosomal abnormalities with the fetus. Well, if those eggs are old and there's an increased risk of chromosomal abnormality, it would also follow that they wouldn't have the same hormone production. So we see people after 35. Now, there's a couple things, though, that you have to realize. Think of your ovaries as your monthly paycheck, right? You get paid every month from estrogen and progesterone. When you retire, you're going to live off your savings account, right? Your 401k. Now, say you get a trust fund when you're 20 and you get tons of money, but then you have a house fire, you total your car, you have a sick child, and you're dipping into that trust fund throughout your career, and then you don't get paid, you retire, and you've got nothing left. Your savings account is like your adrenal gland. So your adrenal gland supplies the hormones for your body to make estrone, to make testosterone after menopause. So that is one big reason why we have so many women having problems earlier and earlier. I just was asked on a podcast this morning, why are we seeing so many girls in their 20s with low progesterone? Why do you think that is? Well, it's adrenal glands, right? When it is a cortisol problem. And we know that when you're running from a bear, you don't need to ovulate. You don't need to reproduce. So cortisol suppresses the pituitary gland, and then you don't have ovulation. So you get a lot of hormone issues. So although we may not call that perimenopause per se, you're asking what age can we think about, 35 and above? But I would say it may not be perimenopause, but you can have a hormone issue even younger.
And sex hormones, not
Yeah.
just, the adrenals can turn it off, but
Yes.
women can start making less and less progesterone and estradiol, right?
Yes. Yep.
Okay. So what symptoms could they think about that would tell them that their sex hormones are off in that range, that 35, all the way up till they stop having periods? What symptoms would tell you in particularly, hey, I have low sex hormones?
What we would see first is progesterone dropping. So the symptoms we usually see is insomnia or problems sleeping through the night, or maybe a little bit more irritability or mood issues, new onset panic disorders, depression. Like you said, what were they given? SSRIs, mood issues, fatigue. Going on, we see a lot of people with low testosterone because stress depletes testosterone, because that's your adrenal gland, right? That's where it's coming from. So you might see hair loss. You might see acne. People who never had acne when they're in puberty, and now all of a sudden they are in their 40s having acne. You might see weight gain, low stamina, low libido, low energy. Those are all androgen symptoms.
And particular weight gain, I mean, wouldn't the weight gain now be more like belly fat, not hip fat?
Yeah, so estrogen weight gain we typically see in the hips and in the breast and sometimes the back of the arms. And so we can see estrogen increase in the perimenopause because FSH increases, and then that's you get more stimulation of the egg. But this androgen, low androgen weight loss, you're right. We see it metabolically in the abdomen. And women will say, I always had a flat stomach, but now I have this roll. And
Right.
that's, as you know, metabolically, insulin issues. Abnormalities in estrogen and progesterone ratio can affect insulin sensitivity. So people get carb sensitive, they get to be insulin resistant.
Yeah. Well, because the belly, that visceral fat or the fat around the belly, it has no place to go. So it ends up being more toxic and more inflammatory and causes more insulin resistance. And whereas the sub-Q. So yeah, I'll tell you what's interesting. Sometimes I see women that come to me in that age, and they just have a lot of pain, like hand pain, feet pain. I don't know if you've seen that a lot.
Mhm. Usually, not always, low estrogen can be the joint pain and the muscle aches, but I've also seen that with low DHEA, which is a form of androgen and it's adrenal hormone. But yes, achiness too, out of character from, what they would expect from exercise. That's another complaint that I see. New onset GI issues, new onset food sensitivities. Sometimes we see that. It's just so interesting. Now, a lot coming out that changes in hormone levels affect the microbiome. And then there's this whole beta-glucuronidase, which is an enzyme produced by the healthy microbiome that if it's increasing your estrogen or decreasing your estrogen. So there's a lot that we're seeing that you and I know from being in functional medicine, that medicine isn't just system. It's all interconnected.
Oh, could you talk more about the beta glucuronidase?
Yeah, so, we all have bacteria in our gut that is called your microbiome. And there are some recent studies that have been published that women who have premature ovarian failure or premature ovarian insufficiency, it's called now, actually, when they looked at their microbiome, it was more similar to males. And so then they gave these women hormone replacement therapy. And what they found is the change in their microbiome went back to what it would be like females. And so there is some correlation. So it's like, which came first, the chicken or the egg? Is it the hormones that affect the microbiome or the microbiome that affects the hormones? So now we know that healthy bacteria and some unhealthy bacteria produce an enzyme called beta-glucuronidase. So if you think about your ovary producing hormones, they're circulating in your blood, it goes to your liver, and then there's 2 steps in liver detoxification, and it puts estrogen in a package and ties a bow, and it goes down a slide into the gut to be pooped out. Well, if this beta-glucuronidase is there, it's going to open up that box and send that estrogen, those metabolites, back into the system. So you might not see blood levels that are high, but the patient may be having heavy periods. And I remember before I learned about this, I'm like, why is nothing working? Levels are okay. This patient's still having estrogen symptoms, fibroids, pain, endometriosis pain, heavy periods, until I learned about the gut and looking at this.
So no, thank you for that. I love your analogies, man. And I'm a very visual person, so I'm
Yeah.
seeing slides and open and doors, and yeah, you're great at this. You're
That's a
great.
teaching thing, right?
Yeah. No, you can tell. You can tell this
Yeah.
ain't your first rodeo. I guess you were just on an inferior podcast earlier today too, I heard. We won't mention which one it was, but yeah, that's good. That's good. It was a good run. But this is going to be the best.
Yeah.
So let's go back. So now you have that, and I think that for the audience, I just want them to know why this is so important. So we talked about gut issues. We talked about I've seen swelling, pain, issues with sleep, gaining fat at the midsection. All this is happening, and all of this is because it could be because their sex hormones are off, but because they're having periods, they're going to be told you're okay. And they're
Right.
not going to be treated, and they're going to be given medication. They're going to be put on antidepressants. They're going to be maybe weight loss medication, but they're going to be just treated symptom wise. And then they spiral because as metabolic syndrome starts to happen, they start getting insulin resistance, and they can get fatty liver, and then they can kind of lead to things like cardiovascular disease, and it kind of snowballs. And if you find somebody that knows what they're doing, and for the practitioners on this show, that's us. We're supposed to know what we're doing. We're raising the bar for functional medicine and integrative medicine. We should be able to be thinking about that, and we should be able to come up with a workup and to help them figure out what's wrong. Now, that doesn't mean every 35-year-old or 40-year-old or 45-year-old that shows up, I'm going to just throw hormones at her. But it does mean be aware of it. Like you said, everything's so interconnected. So let's go to diagnosis. So you have a person, you're let's say there's a lady, she's in her 40s, and she's like, yo, she says yo because she's friendly with you. Yo,
Yeah.
Dr. Scott, listen, I don't know what to do. All my tests have come back normal. I'm gaining weight in the midsection. I'm having issues with I'm having these weird cravings, and I'm having trouble sleeping at night. And you're suspecting this hormone imbalance. How do you diagnose it? What kind of workup would you do?
Okay, so great question. So if you back up and say if she went to those same complaints to her doctor, she's most likely going to either get an antidepressant or a birth control pill, right? And so as I mentioned, the point of a birth control pill is not to replace hormones. It is to create an artificial state to prevent pregnancy. But somehow in the end, it's been analogized like it's the same thing as hormones. Same thing with Mirena. People are like, oh, I have my progesterone in my Mirena. It's very, very different. It'd be like if you had a patient that was a diabetic with a blood sugar of 30 about to pass out, and I said, here, let's give them Splenda. You would look at me and be like, Splenda has 0 calories. That's not going to get glucose to their brain. You're going to give them glucose, right? It's not the same thing. It both sweetens your coffee, but the progestins are not the same thing. So you said, oh, her tests are normal. She may not even have gotten any testing because what us in functional medicine are criticized about from our traditional colleagues is that you don't need a test to diagnose perimenopause or menopause because it's a clinical diagnosis. That is true, right? But you do need testing to see where their hormones are. As an aside, the Endocrine Society recommends for male hormones to test hormones, give hormones, and monitor. The protocol, even for transgender hormone therapy, is test hormones, give hormones, and monitor. But the protocol for women is don't test hormones. They change too much. They're not valid, right? So I don't know what we got the short end of the stick. Now, if you are an infertility patient, they absolutely can check your hormones. They know exactly when to do it and how to do it. So I don't know why it makes such a difference. We know if we want to check your ovarian reserve, we're going to check it on the 3rd to the 4th or the 5th day of your cycle. That's going to see how old your eggs are and what kind of reserve you have. If we want to check if you have ovulation, we check around day 19, 20, or 21. So I don't know why when it becomes perimenopause and you're not trying to get pregnant, those things are no longer valid. But we always start with blood testing, mostly because most of our patients have insurance. Unless you have a high deductible, those tests are covered by their insurance, right? And so we use your standard Quest lab and national lab, and we order labs. We'll check a full thyroid panel. We do a metabolic workup with insulin, glucose, A1C, a metabolic panel, a CBC, and then we check the female hormones, which are FSH, LH, estradiol, estrone, progesterone. We check free and total testosterone with the sex hormone binding globulin, and we like to check DHEA unconjugated and DHEA-S. Sometimes we'll throw in an AM cortisol if we know they can go between 8 and 9 in the morning, but usually we'll plan on getting the cortisol with another test. And so what is the purpose of testing? Yes, it is partially to make a diagnosis, even though we don't need the labs to diagnose perimenopause, right? We just needed to diagnose what is the reason for your symptoms, looking at the root cause, right? We can treat your symptoms with a birth control pill and an antidepressant, but what is the reason for your symptoms? And that's where it's frustrating to me because so many women, just by giving them micronized progesterone, have such an improvement in their symptoms. And I'll ask patients sometimes because, it's a lot of back and forth. Their periods change, their levels change, and it is a roller coaster. And I'll say, is this helping you at all? Do you feel better than before you came in? Because I know you'll have one cycle that'll be heavy, the next is not, the next is 35 days, 23. I mean, it's a crazy time. And 99% say, yes, I feel better. Even though we can't stop perimenopause, we can't change the irregularity, but can we mitigate symptoms by what we're doing? Absolutely. And then we do a lot of, what any functional medicine doctor does. Talks to them about lifestyle, stress management, diet, movement, all those things that can help your hormone balance.
So let's take it back a little bit. Let's talk about those labs. So you mentioned thyroid. Our standard panel is a TSH. We do a total T3. We do a free T4. We do a reverse T3. We do anti-TPO, anti-thyroglobulin antibodies, at least once, just to see if they have Hashimoto's. Are you looking at anything else with that thyroid?
The only thing we do differently is we don't look at totals because totals can be affected by estrogen. So when you have high estrogen, your total T3 and your total T4 are going to go up because your thyroid binding globulin goes up. So we always do the free T3, the free T4.
Right.
Well, we do
That-
the reverse T3 and we do the thyroid antibodies the first time. And if the
Okay.
thyroid antibodies are negative, we don't necessarily follow them if they don't have TPO. And I don't necessarily always do the reverse T3 depending on the patient's budget, but
Right.
yes, the free T3 and the free T4 we always do with the TSH. And
Yeah, theoretically, a free T3 would be better, but the problem is the labs are not as accurate. So
Yeah.
so we like the ratios. So we do a total T3 reverse T3 ratio. And if the level is greater than 6, they're good. If it's less, then that tells me there's an issue. And I know, like, we have a fatty liver course for practitioners, and one of the things that the new drug that's out for fatty liver disease is actually it's a T3 analog. So it doesn't cause
really?
it doesn't cause the symptoms. So it doesn't affect the heart, but it affects other organs. And the reason they realized it is because they were looking at these total T3, reverse T3, or they were looking at like a T4, total T4, total T, I'm sorry, free T4, free T3 ratios. So they were kind of seeing those things off. But yeah, so you do an in-depth thyroid, and then you're going to do, and then you mentioned metabolic stuff, so insulin, C-peptide, A1C, that kind of things. 'Cause
Therapy, yeah, lipids,
insulin, yeah, HOMA-IR score and whatnot. And then you mentioned the sex hormones, and you mentioned how they're available. We get them at the lab, right? But unfortunately, you know what's interesting, Dr. Scott? I've noticed that even people that say they're functional aren't really aware of the timing. So they just say get hormones. They have no idea where they are in their period.
Or what I see is they tell them to go day 3, which you'll never get progesterone elevated in the follicular phase. By definition, it's not produced till ovulation. So
Right.
everyone's going to have a normal progesterone on day 3. So you're right. Either they're not telling them any day at all, or they're saying, just go get this. And
Right.
they're not being intentional about mid-luteal labs.
So what do you we usually do it on day 21, and
Yeah.
then on day 3, which labs look better on or are better for day 3?
If you want to know ovarian aging, then it would just be the FSH and the estradiol. We sometimes, if someone, this anti-Müllerian hormone is supposed to be for people undergoing infertility. It's not really supposed to be a measure of menopause. There's been studies that have been published. You can't routinely use it for a menopause evaluation or a PCOS evaluation, but sometimes we do, depending on if the patient wants to know about their fertility, then we'll do that on day 3. You could do day 3. I've had a lot of patients that start to have a lot of symptoms in the follicular phase. So it really depends on what they're complaining about. It's been really fascinating, like I said, seeing so many younger people. I had some people that say, I feel terrible when my period ends until ovulation, and then I feel okay. So if that's their symptom, and then you're testing on day 21, you might see normal labs. And that has happened to me. I'm testing on 21 and they're like, oh, your progesterone's normal. And then you do what's called a cycle map, where you test throughout the month, either in urine or saliva, and you're seeing these abnormalities that are in the follicular phase. So
And that's the specialty test, right? So
Yeah.
just for the audience, because we get health coaches and we get patients that come and watch, and because they love functional medicine, and hopefully they're spreading the word, and hopefully, hint, hint, anybody that's interested in a career, healthcare, I think, is still a good career, but be a functional medicine, whatever the heck healthcare you're doing. But that being said, the just kind of a reminder of physiology, and correct me if I'm wrong, we start off when first day of the period, when the bleeding first happens. That's the
full flow,
follicular.
day 1.
That's day 1. That's follicular. Your ovaries are making estrogen. Then then the luteal around day 14-ish. You have the luteal phase. That's when an egg is released, and then you have that corpus luteum that is created, and that's when estrogen goes down and progesterone goes up until bleeding starts happening again, and you're back in the follicular phase. So the first half of the month is going to be estrogen, more estrogen released. and the second half is going to be more progesterone. So you're
That's correct,
saying,
except for estrogen does have a biphasic curve. It has a peak at ovulation, then has a second peak in the luteal phase, but it is progesterone dominant in the
okay.
phase.
So do you look at that at all? So what day do you tell them? Do you give them a range? To what day do you tell them to check their sex hormones?
Well, we do shoot for day 19 to 21, but if you have somebody that has a longer cycle, like they know they're always 35 days, you would probably do the luteal phase is supposed to be 14 days. So if they had a consistent 35 day, you might check more at about day 28.
Just pushing it a little bit later, as long as they didn't start having their period.
Yeah, you want to ideally get 7 days before their period starts. Now, you don't know when their period start until it starts. So retrospectively, on average.
Oh, so that's why if they're having a 35-day, you'll go down to 28.
28,
But
yep.
Okay. So for the longer ones, kind of calculate 7 days or a little bit less, right? Is there kind of a window?
I mean, you could do it. Like if they're consistently over 35, you could do it, 30, but you want to try to be mid-luteal, like you said, 21 out of 28 days.
You mentioned 2 forms of DHEA you check. Can you talk about that?
Yeah, so DHEA unconjugated is the largest populous hormone, and I don't know offhand, it's something like 300 to 1200, depending on the stage of the follicular versus luteal, and if the lab will give you follicular and luteal and postmenopausal range, and postmenopausal is like something like 77 to 871. And then DHEAS is sulfated. But what I've found, I always used to only check DHEAS, but I've seen now, and myself, I'm one of them, people have sulfatase SNPs. So their DHEAS is always high. And it's not really indicative of what the circulation of this androgen is, because it's always high no matter if you're supplementing. And then if you have someone who's supplementing, DHEA as a supplement or a prescription has a 48-hour half-life, so they have to hold it for 48 hours. So if they take it mistakenly, it's going to elevate their DHEAS. So that's why I started ordering the DHEA unconjugated, because it's not going to be affected by supplementation. And also because you get kind of like another dimension if someone has a sulfatase SNP that, maybe they're not high, their DHEA is on the lower side.
Nice. And an interesting thing with DHEA, when it is high, it could be the body, when it releases cortisol and it's stressed, it also releases DHEA to counterbalance that stress. And there was some research showing that when people go on steroids, like like prednisone and that type of thing, the prescription steroids, not the anabolic steroids, that one of the things that you can do to decrease the symptoms of that progesterone or whatever is going to be not progesterone, of prednisone. The prednisone or whatever is to give them DHEA, and it will 25 twice a day, and it may decrease those symptoms. So but that's interesting. We're only checking the S, but I think we'll start looking at the total as well to kind of get a picture. So,
especially if you're have a patient supplementing with it.
Yeah.
So I think that's another layer of it.
Helps us with those levels. Nice. So you get all these labs. There's some typical abnormalities you usually see in these labs?
Well, it's interesting because I don't calculate a estrogen progesterone ratio. In some of the functional specialty labs, they calculate that ratio for you, but I look at the quartiles. So for example, a luteal estrogen for at Quest is 44 to 244, let's just say. So the median would be about 144, right? And so, or 184. And so the median of progesterone, again, now the crazy thing is, lab ranges are based on statistical norms. So over the 20 plus years that I've been doing this, the progesterone level has changed, right? So it used to be 6 to 28. Now it's like 1.6. Now, how is a luteal level of progesterone 1 if a follicular is 0.6 to 1.6? There's no elevation. How's that normal? But statistically, they have so many people are getting progesterone levels, drawn that they have changed the normal range. So have to be careful. Anything above 10, we were always taught is a good quality ovulation. So if you've got a progesterone at the lower half of the normal range and an estrogen at the upper half of the normal range, you know, by definition, that's estrogen dominance. But again, there's so many nuances to, is it circulating as estradiol? Is it converting to estrone? That's why some of the other tests are helpful to really demonstrate if they do have estrogen dominance, which is common in perimenopause, but that's usually the driver of many of the symptoms.
So can you tell me about this quartile thing? So you take the range and you divide it by 4? How do you do that?
Right. So 244 minus 44, let's just say, is 200. 100 plus the bottom of it, that means the median would be 144 or whatever it is. It'd be 100 plus 144. So that would be the middle of the range, right? And you can break it down to quartiles if you want, but I usually look, is it above the half or below? It's just easy to eyeball it, right? And so if you are doing a specialty test, they do have those calculated for you, and then they'll have their normal ranges for the ratio as well. So that's nice.
But if you're doing Quest and LabCorp and you see that, you see the progesterone level and you're seeing it 10, but you're also seeing, and you're in that the end of the period, day 21, right? Mm-hmm. And then you see the estradiol, and the estradiol is also kind of a little bit on that higher end.
Yeah, and that's the thing is if you look at the normal ranges for estradiol, it will never be flagged as abnormal. It will never, because they don't designate which range. They'll say postmenopausal less than 54. So that means a 0 is normal. And even if I've seen some really high estrogens come back, it's not always flagged as abnormal because you've got the ovulatory peak, right? And so patients, some of the practitioners are trying to help their patients and they order the labs, maybe at the wrong time or maybe at the right time, but they don't know how to interpret them because they look at it. We look for the red flag, right? And or red or blue, however your report looks. And if they're euboxic, we used to call them, right? If you don't have anything outside the box, those patients are told they're normal because they're not they don't know which range to look at, which part of the cycle to look at. So patients are then still, even if the provider is trying to help an untrained provider, they don't really have that knowledge.
So if having that knowledge, if progesterone is high adequately, but also estradiol is high.
Right. So if you have an estradiol of like 350 and you've got a progesterone of 15, and I had this with the patient that I told you the first time I did this, I did the luteal labs. And she was mounting a day 21 surge, but it was the 5 to 15 that was awful. She had crazy high estrogen, low progesterone. So it wasn't the mid-luteal abnormality. That's why that cycle map, which is either urine or saliva, could be helpful.
Yeah. Okay. So now you're sensing, you're looking, their sex hormones are out of balance. I guess we talked a little bit about regular tests, advanced tests. You kind of talked about that as well. You're doing a urine or saliva. You can do it. You can map it out so you can actually track. It's every other day. Am I correct?
You can. It's like day. I think the urine starts at 7 or 8, 10, 11, 13, 14. So it's not every other day, but it's certain times throughout the cycle. And, 90% of the time we find something in the serum labs, but some of the times we don't. And that's when we would go to a functional test, either being saliva or urine. Now, some of the times, the way I explain it to patients is like, what if you have all the symptoms of high estrogen, but your labs aren't coming high? It'd be if you came to me and you say, I'm bankrupt. I would say, well, why are you bankrupt? Do you not make enough money or do you spend too much? Which one is it? Like, are your bills too high? So that's why when we look at urine metabolites, it may be that the patient isn't metabolizing estrogen. And like we talked about, the beta-glucuronidase is sending it back in, or they're holding on to estrogen, and maybe their serum levels aren't really high because estradiol turns into estrone in the muscle and fat, not in the blood. So that's why it's so kind of confusing to try to weed through this testing issue.
Right. So, but would you say most of your patients you get away with just checking regular blood hormone levels?
I think in a cycling female, especially for endogenous hormones, yes, normally just serum testing. It is nice to look at urine metabolites to see how people are metabolizing estrogen, because that is a source of estrogen pathology, endometriosis, breast cancer, fibroids. All of those patients generally have issues with estrogen detox, whether it's a genetic SNP or whether it's a gut thing or, or insulin thing or something. They usually have some issue there that has led them to be in that situation. That's looking for the root cause because, perimenopause isn't pathologic, right? So it's really just like if we're looking for a root cause, everyone goes through perimenopause. So we can't say that's the issue.
Right. But those metabolites, estrogen doesn't just go from estrogen to out of your body. It actually breaks down into metabolites, and those metabolites have an effect. And those metabolites, depending on their healthy patterns and there's non-healthy patterns. So your estrogen level could look okay, your metabolites are high, and there's an issue.
And to add to that, you have that enzyme 17 beta HSD that converts estrone to estradiol. That it's highly inducible and aromatase. I've had some women that I'm like, I don't understand why their estrogen's so high. Well, because it's aromatase is upregulated, they're dumping their testosterone into their estrogen, but you're not seeing that because it's happening in the tissue. I mean, I explain to my patients, like, let's just say my daughter leaves the house on Friday night and she's dressed in sweats. And I think I'm the best mother because she's 19 and she's going to the library. And then she goes to her friend's house. She changes into a tank top and a mini skirt. She pulls out her fake ID and she goes clubbing. She's making that change outside of my house. So that is not happening in the blood. It's happening in the tissue, and you're not going to see that conversion. That conversion to estrone is really important because estrone acts differently at the estrogen receptor. It wants to cause proliferation.
Right. So so the way I understood it with the whole estrone, estradiol, and one of the challenges with Premarin is that just looking at breast tissue, estrone, if you look at estrogen receptors, there's alpha and beta. Alpha is accelerate, beta is break. That estrone is going to be 3 accelerate to 1 break, which is whereas estradiol is 1 accelerate, 1 break, and then estriol is 3 breaks to 1 accelerate. I mean, it's a simple way of kind of looking at it, but showing that estrone can have a higher impact. And a lot of people don't even check estrone. I check it in men.
I know. And especially for men too.
Yep, I check it in men a lot.
Yes.
Usually when they have a detox. You also mentioned something else. You mentioned aromatase. So aromatase, guys, folks, aromatase is found in fat cells, and insulin actually will stimulate it. So when people eat a lot of sugar, they're going to stimulate it. And what it does is it's going to increase estrogen levels. So even though you don't have ovaries, that's why men will sometimes have high estrogen levels because the liver has to break them down. So awesome. So how do you start let's say you're doing the lifestyle stuff, right? You're working on mindset, you're working on exercise, you're working on sleep, you're working on all that lifestyle stuff. Let's kind of get into how do you start treating them? Are supplements, medication? How do you start handling that?
Yeah, I mean, so obviously, like you said, with any patient, no matter what you're doing you're going to talk to them about their diet. Are they eating inflammatory foods? Are they, having a lot of stimulant? And adrenals are really, really important. What is your stress? You can't control your stress, but how do you respond to it? For hormones, it's really important about endocrine disruptors. So we do talk to them about detoxing their environment, getting rid of plastics, using a reusable water bottle, getting rid of the Tupperware, cosmetics, phthalates, everything. So that alone, for some people, can be really huge in the processed food. It's just doing that and the stress piece. If that's not successful, knowing their estrogen metabolism, whether it's a genetic SNP of those estrogen detox enzymes, we can give them things like DIM, which is diindolylmethanol, which promotes a healthy pathway of 2-hydroxy. Estrone, that 1A1, we can give them things like N-acetylcysteine, which reduces going down the harmful pathway of the 1B1. And then the second phase of estrogen metabolism is COMT. So B vitamins, SAMe, magnesium are great things. Obviously things that are going to help the adrenal glands like ashwagandha can be helpful also. So that would be a younger person. But if you get to the point where you're in perimenopause and you have really high estrogen, I'm really worried about exactly what you said, proliferation of the uterus, of the breast. So we may step in and give them micronized progesterone, which is bioidentical, manipulated in a lab from a Mexican yam to be chemically identical to what our bodies make. And so it is commercially available. It does come in generic. So by most people, it's not expensive. and we put them on a cyclic regimen. So we're trying to mimic natural physiology where you'd normally start producing it on day 15, take it until your next period starts. We're limited to 2 doses of that. So a lot of times we do have to compound another dose if one of them is too low, the other's too high. Sometimes people need it in different dosage forms to control symptoms and control levels. Now, I don't get crazy about chasing these progesterone levels because the levels themselves in any modality, whether it's urine, saliva, serum, are very erratic. So we do look at the levels, but we don't strive for a certain level. We look at the rest of the levels and the symptoms and the history.
So you give them progesterone, micronized progesterone. Practitioners and patients recognize that some of them will have like a peanut oil in it. So if you have a peanut allergy, make sure you're telling the pharmacist. But you're taking it, and this is one of the hormones we have them take by mouth, right?
Mm-hmm. Yeah.
So
it doesn't have the same effect as estrogen in the liver. It's on the opposite side of the steroidogenic cascade. So it's not like,
And you said day 14 till
the next period. Yeah.
Till the next period. And I do the same. Do you ever have them take progesterone earlier if they're having heavy periods?
Yeah, and perimenopause, especially if they have short cycles, we'll start it on day 10. Sometimes we'll start on day 7. We arbitrarily start on day 14. And then if they come back and like, oh, I love this progesterone. I slept so well. I couldn't wait to start it again. Then we'll say, okay, start on day 10 or start on day 7. I have a few people that can't tolerate even the break of it. Now, progesterone we don't really know what the half-life is because it's disseminated in the lymphatics, but it's very short, maybe 6 hours. So theoretically, if you're giving an oral medication, the reason we don't give it every day, 2 reasons. 1, because anytime you do everything every day with a receptor, you build up a tolerance to it, right? 2, we're trying to mimic natural physiology, which you don't have progesterone in the the follicular phase. But there's a few people who say, I can't not have it during my period. So if that's, it's unlikely they'll accumulate. If they're doing a topical, that's a lot of different pharmacokinetics because it's going into your subcu and it's staying in there. So you do want to break so that you don't accumulate like snow, like once it snows in Minnesota, they never see the ground until summer, right? But in Ohio, the streets are clean the next day within a few hours, So with topical, even more so to want to have a drug holiday.
Right. The stacking. But the typical, maybe day 10, maybe day 14, till they start having a period, then they stop it, right? And then the progesterone that decreases the need for estrogen, decreases estrogen receptors. What kind of improvements do you see with them just going on progesterone at night on those days?
The sleep is huge. I mean, people say the sleep is wonderful. The moods are better because one of its metabolites binds the GABA receptor, which is like taking Xanax, chilling you out. It does downregulate the estrogen receptor, like you said, and causes apoptosis in the uterine lining. So it prevents hyperplasia. So they might have a washout where they have a heavier period at first, but they generally have lighter, shorter periods, less cramps. It's also a 5-alpha reductase inhibitor. So that's the enzyme that converts testosterone to dihydrotestosterone. So it can even help with acne when people on perimenopause are having that. So usually that's what we're seeing. Now, again, as I mentioned, everyone's going to go through perimenopause. We're not trying to stop it. They're still going to be irregular. They could regulate, but they might still be irregular. And that's what you have to educate your patient is I'm trying to help you with your symptoms and make you feel better. This isn't going to stop the craziness.
Yeah. And I think that's what we're not treating numbers, we're treating patients. And there were some women and not having a period, it happens, right? That's part of life. But I heard there's women in maybe certain populations that just, they know they're in menopause because they just stopped having periods. That's it. Right. Not all these symptoms and not all of these, but I think our environment kind of sets us up to having these severe symptoms. And we could go on and on just about that
there are some lucky people that just stop their periods and don't have. My sister's one of them. I mean, she's like, I'm not having any hot flashes. And then, after 2 years, I said, let me sit you down and tell you the risks and benefits. She decided to try hormones. She's like, I had such bad joint pain. She didn't associate that as a symptom. She had no hot flashes, no sleep issues. So.
And that was her symptom. Right.
That was
Right.
her symptom. And once she started taking hormones, she's like, oh my gosh, I feel so much better.
So progesterone, you start at 100 milligrams, and then, and of course, you can do a 50 compound or a higher compound, but you start at 100. What would make you increase it to the 200?
So how the cycle is, if they're still having heavy bleeding, if they're still having short periods, a cycle less than 28, we used to call it a luteal phase deficiency in fertility patients. So that's basically low progesterone. So if they're still having these short 24, 25-day cycles, that could be a sign. If they're still having night sweats and not sleeping, that could be a sign. We do look at the levels, but again, like I said, they could be kind of all over the board, especially with non-compounded immediate release, commercially available. You could see high levels to low levels all over the place.
Right. And I think it only has like, even the compounded, it may extend it a couple of hours, but it has a shorter kind of 6 to 8 hour window, right?
Yeah, you can you're not supposed to say slow release, but there's sustained release. You can say slow release, or you could slow it down with the
Okay.
compounded hormone. But you're right. You're still,
Why don't you say extended release? They cancel you?
I think yeah, I think it's a pharmaceutical thing that the compounders aren't allowed to say because maybe that's
Oh, yeah.
proprietary, yeah.
Yeah, dude, if I get canceled, it's not going to be for this. I'm telling you, I will not say extended release again. We're
Yeah,
done.
right,
Nope.
right.
Sustained
Yeah.
release. Okay. So you start progesterone, you start the 100, then you think about 200. Now, have you noticed that sometimes you put people on the higher dose and then their symptoms go back or they feel worse?
Yeah, you can get what's called tachyphylaxis. And so that's the thing about these hormones is it's a bell curve. It's not like a straight linear, more is better, right? Once you get down the other side, your symptoms are going to be the same of too much progesterone as not enough. Now, we in the US, patients can go on Amazon and get progesterone cream, right? I've even seen they get estradiol now, which is crazy. So they can overtreat themselves. The canned directions for progesterone cream is 20 milligrams twice a day, which is not a low dose at all. It's kind of a high dose, and they don't tell them to cycle it. So they can overtreat themselves with progesterone and have the same symptoms.
Yeah, and the stacking that you're talking about, like, so it depends on where they're putting it and whatnot. But just for you guys listening, like, you put on progesterone cream, and some of it gets stored in the fat, and some of it goes in the blood, and then you do it again, and some of it gets stored, and you do it again, and some of it gets stored, and then eventually, even the days you're not taking it, your fat is just releasing progesterone in. So you stack, 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 and then you leave those high levels. But like with a pill, like you mentioned, that sometimes what I've seen is a U-shaped curve. Like if you start increasing hormones, more isn't always better.
Right.
Sometimes you go higher and they actually get worse. And then you have to back down and then they feel better again, or they start having new symptoms. And I think, you know what, one thing that I don't think we talked about yet is that the progestins that a lot of times the practitioners will call progesterone and progestins and isn't there like a progesterone or some weird thing like that where it's kind of confusing what they're talking about and that they're different compounds?
Yeah, the clinical term is progestogen, which includes progesterone, micronized progesterone, and a progestin. So anything that's medroxyprogesterone acetate, levonorgestrel, norethindrone acetate, those are all in birth control pills. Levonorgestrel is in the IUDs. Those are all synthetic progestins, either derived from a testosterone-like molecule or a progesterone-like molecule manipulated in the lab. They do not have the same receptor affinity. So you mentioned that the estrogen has alpha and beta. The progesterone is a supernucleus complex that has an androgen site, a mineralocorticoid site, a progesterone site, an estrogen site, and one more. There's 5. I'm blanking on it. But so it's a much more complicated receptor. And so if you look at the receptor affinity of something like MPA versus micronized progesterone, it's clearly different. I mean, you have progestins like drospirenone, which are anti-androgenic, right? So they're not the same. That's why I tell patients about Splenda and the glucose, because they're clearly not the same thing. If you want to prevent pregnancy, great. If you want to treat endometrial hyperplasia, great, cause apoptosis, but you're not going to get the GABA, you're not going to get, from that, you're not going to necessarily get you're not going to get downregulated of the estrogen receptor. You're not going to get 5-alpha reductase inhibitor. You're not going to get any of those other things. You will get the same action in the uterus. However, progestins have been shown to have the opposite in the breast, whereas estrogen causes growth. Progestins, specifically MPA, causes anti-apoptosis, which is a double negative, which my mom, who's an English teacher, told me never to do. But anti-apoptosis is growth and more growth, right? So that's where Premarin and Prempro caused the issue with the Provera, causing the opposite.
And what's interesting is patients will then go, you give them progesterone, and they'll go read, and they're reading about all the side effects of progestins.
Yeah.
And they come and say, oh my God, I think I'm gaining weight from this. Have you seen that?
Yes. And I tell them, and, I have all these text macros in my chart that will say, in the package insert will tell you that it's an increased risk of breast cancer and blood clots. But this has been specifically studied in multiple studies, head to head, and does not have that same effect. But your package insert will say that because it's the same category.
It seems so irresponsible that they just shoved them all together, and they're calling two different compounds the same compound. It's like saying, hey, be careful of those blood pressure medicines because they could potentially cause side effects, right?
Right.
They could cause you to pee more. Well, there's some that cause you to pee more and some that don't cause you to pee more, but they just kind of shove them together. And that is one of the frustrating things, because patients will start reading those symptoms and they come back scared. I'm afraid I'm going to get a blood clot, or, oh my God, it says I'm going to gain weight. When what's interesting is progesterone makes you go to fat as a fuel. It's the pregnancy hormone, so that you got to that uterus has to or the baby has to survive. Whereas progestins, they gain weight and they get swelling and they get the opposite effect. So yeah, I think that's one of the big misconceptions out there. And then the conventional docs. Well, you don't know how many times like you'll have these OB-GYNs and they'll say, yeah, you're not better with the progesterone. It must be placebo. And the patients don't believe them, but the patients will come back and tell me.
Or they'll say, you have progesterone, you've got your IUD.
Oh, yes. Completely different. It's a progestin. All right. So now we put them on progesterone and they're better. Do you check an MRS on them? Do you have a screen, like a questionnaire that you give them?
Oh, like an MSQ.
Yeah.
We have a symptom assessment that we just had part of our EMR, review systems. So we don't have an official one that you can score, side by side. We just have the same review systems.
So I use, in our practice, we just use the regular MRS that you do for the menopausal women.
Okay.
So because it's the same, it's a hormone imbalance. So we check that because it's always nice to see that number. But of course, in our large MSQ symptom questionnaires, you can see that as well. But always when they can see those symptoms, it's helpful. So now you've given them the progesterone and they seem better, but you're like, man, this person probably should be on estrogen, even though they're having periods. Do you do that?
So you don't have to wait till you've had 12 months without a period to start estrogen.
Okay.
But you could be fooled. So I like to see more than one level of estrogen that's low, and history, right? So late perimenopause, the definition is 60 days between periods. So once they've skipped a period, you can say that ovarian function is probably declining. Now, I've started people in their 40s on estrogen that are still cycling, but you have to be careful because once in a while, if they have a high FSH and a lot of estrogen, then you can get what's called luteal out of phase cycles, where you get so much FSH, one ovulates and the other one ovulates right behind it. So period, 2 weeks later. So accumulation of estrogen from two follicles, they can have crazy high estrogens. And what's going to happen? They're going to get breast tenderness because you've given them estrogen. Now their bodies change what they're producing. So in a person who's very, aware of themselves, that can understand that concept, I will offer them estrogen. If they're not going to understand, they'll think, well, I took this estrogen and it caused a symptom. No, your body now changed what you produced, So yes, it depends on the situation. And I'd like to see several estrogens that are consistently low and the clinical scenario fit with this. If you get one aberrant estrogen that's low and they have no symptoms, then we'll let it ride and keep following them.
But you're looking at estrogen on day 21?
Yeah, theoretically, yeah. I
Yeah.
mean, we are. And again, which is why if everything was free, it would be so great to have those cycle map tests. I don't do them a
Yeah.
lot because they're pretty costly. But the last couple people that I've run them on, they're really good cases that I've seen, pathology.
Now, the estrogen you give, are you giving it in the form of a patch? Are you using a cream? Are you giving him a pill?
Yeah, so I don't use oral estrogen for several reasons. One is because of the blood clot risk, but
Right.
also another big one is once you give someone oral estrogen, you're essentially decreasing their free thyroid and their free testosterone because you're increasing a binding protein. There's also some reports that it interferes with serotonin metabolism. So it's the blood clotting, it's the binding globulin, it's the increases your CRP and your triglycerides. So we don't use oral estrogen, and there's so many options of transdermal. You don't really need to use it. 90% of our patients are using a patch. If they have a latex allergy, there is a generic estradiol gel, what's called Divigel, that comes in 4 or 5 strengths. That's a small. Now, here's the thing about the estrogen gels. They all have different half-lives. So I trained with a pharmacist, so I pay attention to this stuff. So they're different concentrations, they're different half-life. So if you're putting on a drug every 24 hours that has an 18-hour half-life, you're going to get more accumulation versus a 10-hour half-life, right? So Divigel, estradiol gel, that's those little packets, has a 10-hour half-life, so that's my preference.
Nice. Yeah, we do a lot of the patches. I'm so glad to hear that you don't give the oral estrogen because there's like a group within the functional medicine community that are taking a course and they're being told that
Oral link. Yep.
oral is the way to go. And it's like a cult. Like I feel like I'm going to get stabbed when I tell them no. They're like, no, it's different. It's different. It's a different thing.
They're claiming that, they're claiming that oral is the only one that has data for bone protection and brain protection. Most of the studies are done on oral. That doesn't mean that oral is the only one that gives you that protection. No. That's where that comes from, that exact course. You're right. So no, I don't ever use oral. Yeah. I have one patient that was badly burned over most of her body. So she takes a troche because she has nowhere to put anything transdermal. But that's sublingual. That's not oral.
Right.
So other than that, I
stay away from the troches just because you don't know how much they're going to swallow, right?
Yeah, they are invariably going to swallow some of it. You're right. Yeah. But so normally it's patches or it's the Divigel, or you can do a compounded biased, totally different drug though, works differently. So for a lot of patients that are between doses or can't seem to tolerate that estradiol, they do better on biased. It's a little bit harder to monitor though when you're doing biased because you're not going to see serum elevations in topical gels or creams. You will with the patch, won't with the topical creams or gels.
You won't see serum elevations, you said.
Yeah, serum can underrepresent. I mean, so the person who started the Dutch test and I did like a study on a patient, right? So we did patch and oral progesterone and had her take that. And we did every day, we did urine, saliva, and serum. And on the last day, we did serum every 2 hours. Then we'll washout period and have her did the gel and the topical progesterone because she didn't have a uterus, and same thing. So with the gel, the last day of 2 weeks when we did the every 2 hours, you did see an elevation, but that's, accumulation. You will, because alcohol gels really drives it in past the stratum corneum and the epithelium and everything, epidermis. So you will see it elevate after a while, especially if you're doing some of those other preparations that have an 18. One of them had a 48-hour half-life. So we're dosing these people. And then there's I saw another influencer showing how to put on the Evamist, which that spray, I loved that spray, but the dose is crazy high. It's like 8 times, it's 1.5 milligrams, and we're starting people on 0.25, 1.5 per spray. So it's 1 to 3 sprays, which I love how it goes on, but it's a really high dose. And I don't remember offhand what that half-life is. So when you're doing this and you're doing a daily dose, you do have to pay attention to the half-lives,
Well, this is exactly why more people need to follow you and me, because the one that has the most followers is the one that's usually right. And I really believe you're right. We got to see how many this influencer has.
Yes.
Yeah.
Well, and I think that person that's teaching that was an ER background. Not that nothing wrong with that, but I just
Nothing wrong with that, but yeah,
Yeah.
they can be a little intense. But listen, so the people paying attention and listening, I know I have some people that I love dearly that are giving oral estrogen.
Yes.
Just because you've heard this doesn't mean that we don't love you. We just don't agree with you.
Right.
And you can take the rest. And I don't want to harp on this too much, but I'll tell you. So the fatty liver disease course that we put together, one of the things is that oral estrogens can worsen fatty liver, and it can cause cholestasis.
Well, the other thing with the oral estrogen, it's not going to the body as estradiol, it's going to estrone. It's conjugated
that first
to
pass.
estrone sulfate. And so you're not
First
giving
pass.
your patient estradiol, you're giving them estrone.
And little pearl for y'all, because I don't think we mentioned it, but when that estrone is high, I usually put people on that sulforaphane. And that seems to really help drop it. But that being said, I think what days, if somebody's having regular cycles, but you feel like they're low in estrogen, what days of their period will you have them take estrogen?
Now, if they don't have menstrual migraines, say those aren't their symptoms. So if they have a menstrual migraine, I will have them take the estrogen through the cycle. Because that's
every day. Okay.
Well, some of the patients in perimenopause, I'm having them start it a couple of days before their period and just take it that week of their period and then stop.
Okay.
That's for menstrual migraines. But for someone who's perimenopause, usually we have them stop both the progesterone and estrogen for 5 to 7 days of their cycle and then restart.
Okay.
So it makes it easy. Now, part of the reason we do that is just to make it easy for the patient to stop both. You could get fancy about giving estrogen for day 3 and then starting progesterone on day 4. You got to make it easy for them. So
Yeah.
Are you bleeding?
I might be too fancy because what we're doing is we're having him do the patch on day 1 to day 21. I'm sorry, day 1 to day 1 to 21, and then we have them do the progesterone day 14 to day 28. So am I too fancy?
So that is archaic, Dr. Elyaman. That was how that used to have prem phase. So that's where that came from. That's how that was dosed. So they used to have prem pro and prem phase.
Yeah.
That's
they feel better though. Does it help?
Yeah. I mean, I don't think there's anything wrong with it, honestly. If they don't have symptoms and those days at the end of the cycle when you take that estrogen away.
Yeah.
And I even have people that in the late perimenopause, when they're having sporadic periods, they're taking it every day. They can't, you could do.
Well, I think that's where timing is important in the beginning, but as it starts to spread out, sometimes I just have them take it every day.
Yeah.
So let's say they're spreading it out. Let's say there's 60 days. They're on every 60 days they're having their period, or just even longer than that. You have them take progesterone. You have them take estradiol. Do you have them just take the progesterone every day?
Mm-hmm.
And then the estradiol, you have them do a break. Let's say they're doing patches.
Not at that point, no. I mean, if they're menopausal and they're not having ovarian function, we could do 1 day a week off. Honestly, it's all
otherwise just every day.
Yeah, because if you're using a patch, once you take that patch off, it's out of your system in 24 hours. I don't usually see accumulation from patch use in most postmenopausal. You can in perimenopausal. So the science is that, drug holiday and menopause, so again, it really just depends on the clinical situation.
I just realized my kids call me old. You called me archaic. Man, I need to start doing more push-ups.
I know I'm older than you, so I pot calling the kettle black, so.
Impossible.
Yeah.
Well, Dr. Scott, thank you so much. This has been amazing. I'm sure that we are going to get amazing reviews on this one. I'm so happy that you did this. And now it's time to spill those functional medicine beans, those things that you're not going to learn from AI. You can't just Google. Your clinical experience share. To unlock additional premium content, including the deeper dive in this clinical topic, leadership and speaking tips, charting and efficiency pearls, and business mastery as a functional medicine practitioner champion, be sure to check out our mastermind and other membership programs at www.fmpessentials.com. Hey everyone, we hope you're enjoying the FMP Essentials show so far. Pretty amazing, isn't it? Remember, if you're part of our mastermind, Don't miss out on our exclusive bonus clinical content. That's where we take a deeper dive, look at personal experiences and real world insights that you can't just get from a book or from looking on AI. It's where we really get into the nuances that make a difference in your practice, the experience of the guest of our show. Thank you for watching, and we hope you enjoy the rest of the show. So, looking at the functional medicine practitioner as a fruit-bearing tree, the fruit actually have seeds, and those seeds can be planted. And that really is our legacy. We plant our seeds through mentorship, through community involvement, giving back, making sure that our impact goes way beyond our individual practices. For those of you at home that are listening, I want you to think about those friends or those family members that are looking for a career. Maybe they're in healthcare, maybe they're not in any type of career, and really share this show with them. Let them let them listen to the show. Let them listen to what functional medicine is like, because what you can be a massage therapist that is looking at everything with a functional medicine lens. You could be a health coach. You can be a physician. You can be a nurse practitioner, PA, naturopath. So this show is actually one of our ways of giving back. And that being said, with Dr. Scott, I would like to, before we kind of get into legacy and giving back, what areas of study or work, what are you excited about right now? What are you working about right now that you're ready to announce to the public?
It was the book, but I'm really excited that so many younger people, if you look at my demographics on social media, it's 25 to 45. And so I'm so excited that that age is aware of their hormones, they're more mindful, they're more proactive, they want to have optimum health, and they're coming in and they're seeking health. And you can vet your practitioners on social media. And so they're finding me, people are coming out of state because they want to be better. And so I'm thankful that they're advocating for themselves and they're not just settling with take a birth control pill or you're fine, your periods are normal. So I'm excited that the word is reaching those people who had in the past had been suffering.
And you are. So you mentioned the book, but the book that was for people that are in that private membership. So you are writing a book on perimenopause. Yes, you are.
No, on hormones from
On
puberty
hormones. Okay, on
until
hormones.
perimenopause.
Do you have a name yet?
It was the Hormone Guru's Guide to Longevity, but now I'm not sure. We'll see.
Okay, so there is a book on hormones that you guys are going to need to buy as soon as it's out, and you're going to have to look her up on social. You're going to have to follow her on social. You're going to have to keep reminding her about that book so we can get that book out, because it needs to be after. I am sure this book, the world needs this book. So it's time to help the world legacy-wise in that regard.
Yeah.
What are some impactful ways that practitioners can contribute to their communities?
Well, I mean, I did a lot of free things. I spoke at a health food lecture series a lot, that was just educating the public. I mean, all the times like Tuesday, after I get off on this, I'm going to do YouTube Live and TikTok Live. That's when we do Tune In Tuesdays. And so answering questions for free on patients, whatever we can safely without giving medical advice, putting, all that social media, all the free access that we have, putting together for patients to advocate. So practitioners can do that. There's a lot of scatter out there and it's hard to know who to listen to. Fast, don't fast, train, don't train, eat protein, don't eat protein. You know what I mean? So I think, just putting in my little corner of my world, putting out things that can be helpful. That's what I try to do.
Can you share experiences or initiatives, like a specific initiative that you were involved in that you felt like really made a difference?
I mean, I think I've been asked to speak a lot about breast cancer, and I feel pretty called to be preventative, not just early diagnosis, to identify the high-risk patient. I did have a poster that was accepted at the Menopause Society about this exact topic, where I feel like, there are ways to identify a high-risk patient well before this, not just by imaging. So, I mean, I think people are, with the genetic mutations, people are aware, they're being more proactive. And so in general, it's kind of like the same answer to the first question. I just feel really good about people who are coming and they're trying to get answers. Maybe they have endometriosis and they have a lot of pain and they don't really know. And I can think of a patient that drove 4 hours to see me and she's pain-free now, after so many years. And that's not always what everyone's going to experience, but for that particular patient, it was.
Right. We actually had Liz Boham, Dr. Boham,
Yeah, she's
and
great.
she talked about breast cancer. And
Yep.
a lot of people, unfortunately, people will be diagnosed with breast cancer and just say, take chemo and that's it, and eat whatever you want.
And that's
And
it. Yep.
that's not the case. It's no, let's make sure your family doesn't. Let's do everything we can to decrease your family's chances. And yeah, no, awesome. So what about kind of donating larger scale? I know I like donating to the environmental work group. I feel like they're doing a lot of the work that really our governments should be doing, but they're not. So they're really helping with awareness of chemicals and toxicity. The Institute for Functional Medicine is a non-for-profit. A lot of people don't know that. So I'll donate to them. Are there any particular organizations that you feel like we should donate to kind of help the integrative functional medicine, personalized medicine cause?
So I donate to an organization called Girls on the Run, which embodies young girls in, I think even before middle school, to exercise and, advocate for themselves. I don't know if you know that my daughter is a paraplegic. She's paralyzed from the waist down after an injury. And so she's involved with a nonprofit injury organization called the Roulette Foundation. And so I donate to them because they are all about women's empowerment for women with disabilities. And so they have an annual experience in July where women all over the world come and, you see 200 people in wheelchairs, like all at everybody's same level. So I'm involved with them. Also we have our local marathon, Akron Marathon. So it's all about getting people out because they have a relay. So you don't have to run a full marathon. You can run 5 different segments. So it's all about promoting health and getting out there. So those are some of the things that, aside from just like, Compassion International, and other things that I donate to.
Awesome. Awesome. So how do patients, how do practitioners, how does the world stay connected with you?
So mostly people will connect on social media. I do have a YouTube channel, Hormone Guru, and you can find me by Tara Scott. We have subscribers. We have a weekly free newsletter that comes out about hormone insight. I've got a free mini course that is also available, free downloads on a testing guide to perimenopause and also natural therapies for like depression, antidepressants, mood issues.
Nice.
On Instagram, I'm Hormone Guru MD. On TikTok, I'm Hormone Guru. And so that's usually where people follow along. We are trying to get more subscribers to our newsletter so we can get the word out, and certainly on YouTube as well. So we've been trying to work on that.
Awesome. So if you look at where we talked about many things, the most valuable thing that we have is our time. And you have been so generous with your time. And for that, I am very grateful. Thank you so much for coming on the show. I know we kind of talked about your book coming out now that it's actually happening. Once this comes out, it takes about 6 months, but I look forward to putting the link to your book in the show notes. So everybody, if you're watching this, check the show notes. That's where the link to her book is going to be. But thank you so much. Bottom of my heart, awesome work you're doing. Thank you.
Yeah, and you're welcome. I know it takes a lot of work to do what you're doing, and so you're having a heart to serve and get the information out there. So thank you for your time.
My pleasure. Hey everyone, I'm Dr. Yousef Elyaman. We hope you enjoyed the show. For more exclusive content from this interview, check out our FMP Essentials Mastermind. Make sure you check out our website at www.fmpessentials.com for our blog and other content. If you enjoyed this show, please subscribe. Give us a like. It helps way more than you could imagine. Thank you for watching. Follow us across all social media platforms at FMP Essentials HQ. Please don't forget to share this with your practitioner friends, and we'll see you in the next episode.